It's a huge privilege and challenge to be on this program this morning and speaking after Atul. Normally, in sporting analogies, one has the curtain raiser before the main event. I feel on this occasion we've just had the All Blacks playing Australia, and I'm Wellington Boys High School versus Christchurch College, and I greatly appreciate you all staying with us and paying attention. So I'm going to talk about communicating for safe surgery and look at some of the challenges we've got, look at what it is that we have done in the Commission, and look at some of the plans that we've got for the coming year. Atul's talked to some degree about what safe surgery is in terms of safe anaesthesia, safe environment, and the availability of surgery. I'm going to talk more on the communication side, and safe surgery in this context is that everyone has a clear understanding of everyone's roles, that there is mutual trust amongst the team, and that there is effective closed-loop communication, with the end result that surgery is error-free. This list of relationships between communication, leadership, and teamwork outlines some of the specifics that we need to consider, but I've highlighted three in particular. Teamwork is impossible without good communication, and if it's done poorly, it leads to errors and omissions. And good teamwork requires effective leadership. So what is good teamwork? What are the features of good teamwork? Well, Silas did an extensive review of the literature back in the early part of the 2000s and identified these 5 characteristics which were associated with good teamwork. I think we can all appreciate leadership. Somebody needs to be calling the shots, and as has already been mentioned, many patients feel a deficit in their healthcare is actually that there is no leader. But a good team has more than just a good leader. You've, I'm sure, heard of the term followership. Well, probably many of the aspects of the other 4 components are encaptured in that particular phrase. Mutual performance monitoring, making sure everyone's doing their job okay and whether they need some help. Thinking of the things that might need to happen if something didn't work, what backups were required. I think the next one we're actually pretty good at because the healthcare environment, particularly in the operating room, is quite fluid, and adaptability is something that most of us pride ourselves on, both medical, nursing, and all the other health professions that work in the operating room environment. And of course the team orientation, that this is all about the team's output, not about my individual expectations for my day's work. So that's all very well. We all do that pretty well, don't we? We're all pretty optimistic. So can we rest on our laurels? What's the evidence that we need to do anything at all? Well, perioperative harm does occur. And there are the classic examples: retained swabs, retained instruments. And on the national and international scene, now I know you can question, we could have a long forum about whether we believe all of these results are measured in the same way. And yes, you could say, well, we're in some very good company in some of these things, Canada, Switzerland, etc. But it doesn't look, at least as far as these data are concerned, that we can rest on our laurels. If we look at DVT and PE, this is 2012 data, you can see that the number of patients that we had who had VTE events, either deep vein thrombosis or pulmonary emboli, was substantially higher than the OECD average. If you look there for New Zealand, 1,288 compared to 461. And if we look at sepsis in particular, we're again well above the OECD average with 3,341 cases of postoperative sepsis after abdominal surgery compared to the OECD average of 1,749. Just taking data from the Commission over recent years, you can see that the number of perioperative harm events has certainly not plateaued. Now, I know this is partly to do with better reporting, and that's all great, but would be nice to see that if we were going to rest back and say we don't need to do anything, that it was at least level or possibly even going down. So what have we done? Well, we've heard about the checklist, and we've been made aware of the checklist, and we know from the Health Quality and Safety Commission's data that's reported quarterly, or has been reported quarterly, that 90x% of times, operations, the checklist is used. But is that all there is to the checklist? Because I think you in this audience would appreciate, and the Litmus Group, when they did a survey for us a year or two ago, reported that there is a general lack of understanding of the intent of the checklist. We have used it in a way that has been a compliance document. We have used it to tick the box and to get two people to sign at the bottom, so that if anything goes wrong, we'll certainly know who was to blame for it. Patients generally are less concerned about who's to blame if something goes wrong than not having it go wrong in the first place. And the analogy, the aviation analogy, is it wouldn't be terribly useful for the pilots to have signed the checklist and got it wrong. You'd certainly know that they were responsible when there was an event, but most of us would rather it didn't happen. And why does it happen? Well, there are some personalities, and we recognise them all. They're part of our teams, all of these. The ones who are helpful are the ones in the middle and the top, the quality improvers, the team players, the risk protectors for different reasons. But the day-to-dayers and the disgruntled compliers, we've all worked with them, people who come along, do what's necessary, those who are overtly antagonistic, more of this bunkum, but they go and do it because it's mandated. But it doesn't really produce the results that we need. Well, do we need to produce, surely just having the checklist there by itself will be enough. It's a very powerful message. Is it not enough by itself that it will produce the effects? A bit like the Hawthorne effect of any data collection. Sometimes just having somebody there saying, we're going to look at something, actually makes a difference without anything else at all. Well, these are the people that we like, the quality improvers, the risk protectors, and the team players. The disgruntled compliers, they are the ones that see the checklist as a challenge, and they feel the checklist is unnecessary and adds to the time of the procedure. And the day-to-dayers, they're not pushing the barrier, they just come along and do what they're told to do. But it does make a difference. This is one of many papers. This is just the most recent one from Aradazi, published in the Annals of Surgery this year. But it produced the same results, or the same sorts of results, as the Norwegians produced last year, and as the French produced and the Dutch produced. In every different group that's looked at it, it is more than just having a checklist. It has to be done, and I'd put it to you, it has to be done well. In this Aradazi paper, where the incomplete checklist was performed, the complication rate was 16% versus 11% if it was completed in its entirety, and the mortality changes are similar. In the New Zealand environment a few years ago, we looked at how often our checklist was being used, and we found similar things, that the compliance range was at the lower end of the spectrum, and nowadays I think it is probably, we're doing better than that. But it's not just about, this is the form that we used to use at Auckland Hospital, and I'm proud to say used to use, because we don't use a paper checklist form anymore. We have a wall-based chart. And by using a wall-based chart, we're able to get all members of the operating room team, the anaesthetist, the nurses, the surgeons, all engaged in using it. We don't have to defer to somebody who's got a clipboard with the chart. And with permission from Simon Mitchell, one of our anesthesiologists, I'm just going to show you the results from a study, or some of the work that we've started to do with this particular paradigm of using the checklist as a wall-based chart. And because this group, of which Alan Mary's a big part, has done work like this previously, they can compare the result of engagement with the wall-based chart with what was previously the case with the paper checklist. And we've measured it using this Hubar's assessment. It is a Likert type scale, a 1 to 7 scale of engagement. And you can see the little prompts at each end, and for those medical clinicians, this is like the prompts we get for grading our registrars as to whether they've been really good, average, or perhaps not so good. And for example, you can see at the top end of the scale, engagement, examples of engagement. All team members stop other activities and concentrate on the checklist. Somebody asks a question about something that he or she did not understand, or the anaesthetist refers to the patient chart to verify critical patient information. At the other end of the spectrum, the non-engaged side, key members talk on the phone or to each other during the timeout. The surgeon says something like, let's get on with the checklist. This is very muted down, I'd say. Surgeons often say some things that, or have said things which are much more radical than that. Then walks out of the room while the checklist is being administered. You can see those. So what are the results? Well, here are the results. So this compares the data in this most recent study, the 2015, with 2 previous studies of checklist engagement during which the paper-based checklist was employed. And in sign-in, because the way it's done, at least in the Auckland hospitals, and I suspect in many other hospitals in New Zealand, really it's only the nursing and anaesthetic teams that are there. So the ideal would be to have those teams fully engaged on the Hubbard scale, or even present would be a good start, but certainly engaged. The timeout, we expect all 3 teams to be in the operating room, as we do with the sign-out. And because they were different studies, this wasn't put together as a longitudinal study. There's insufficient data in 2011 to look at sign-out. But you can see, and I suspect, remember the original checklist study was done in Auckland in 2008, that we're getting some fatigue, checklist fatigue. It's a well-known phenomenon. And in 2013, only 39% of the time were we getting 2-team engagement in sign-out, 15% in timeout, and 9% in sign-out. So this is having all the relevant teams and getting high scores on that Hubbard's engagement scale. Using the wall-based checklist and engaging the individual team members, the changes here are substantial. The engagement, particularly in the timeout, getting the surgeons engaged in the timeout made a substantial difference. We're clearly still struggling with the sign-out. I fully acknowledge that. It's a work in progress, as indeed are debriefings, but I'll come to that a bit later. So this particular paradigm is one which improves the performance of the checklist. So checklists are not just compliance documents, they're not just tick boxes, but also we need people to be more than there. We need them to be more than day-to-dayers. We need them to be involved in this process to make it really work. That's the same data in a graphical form, and you can just see the 3-team engagement in the timeout is substantially different than we've ever been able to demonstrate before. So what else have we been doing in New Zealand to improve the checklist compliance, team engagement and safety? Well, we had the PricewaterhouseCoopers team working for us in Lakes, Waikato and with Southern Cross to look at a number of initiatives to improve teamwork and communication. And their what was called proof of concept project, and there'll be a number of people in the room that were actively involved in this, aimed to improve teamwork and communication by using briefings, using the checklist effectively, and using debriefings, and at the same time effectively ensuring VTE prophylaxis and surgical site infection protocols and guidelines were followed. Some of the things that they specifically did in relation to communication was the use of feedback, call-outs, closed-loop communication, critical language, cuss words, ISBAR, and the 2-challenge rule. Now, I'm not going to go through all of those, but I bet you there are some things that many people in the audience would be unfamiliar with. I certainly was before I looked at some of their work. One is the cuss words, which sort of sounds a bad thing, but they are words that imply either that somebody's concerned, uncomfortable, or scared. 3 different levels of escalating worry about what's going on in the operating room. And for that to work, everyone clearly needs to know what the individuals are talking about. Call-outs, where people shout over an important piece of information, often more more commonly used in an emergency situation, but obviously useful in the operating room from time to time. And critical language, whereas an agreed terms of phrase in the operating room that forces everyone just to stop and think about what's going on. And it may be something which individuals have determined is appropriate, or is agreed words for that operating room, or indeed for the whole operating theatre suite, whereby using that language, the sort of classic understatement that we're known for in New Zealand, I'm a little bit worried about how things are going on here, might actually mean, I think this patient's going to die in the next 5 minutes if we don't do something. But we sort of downplay it. She'll be right, I'm sure it's fine. I'm a little bit worried about this, but actually we mean something entirely different, and sometimes that doesn't work in our favour. We also, through the proof of concept project, introduced briefings. And this is something, and there's a checklist for briefings, and I'll perhaps go into that. There's 2 parts to it, but the checklist or guide for briefings, again, it's not something which you have to check off. I've got a little copy of this in my loops, so when I go into the operating room and open my magnifying loops, I've got the list there so I can remember all the things to do. And introducing the team members, in my personal experience, this is a very powerful way of getting people to feel that they're part of the team, part 1 of what we're talking about today, and communicating. It's great in the checklist, in the timeout. We should make sure we know who's physically in the theatre and that they feel comfortable in identifying themselves. But this is the time that people say, do you want to use this piece of equipment today? Or did you know that the Minister of Health's coming to visit us at 10 o'clock? So, there'll be a bit of disruption outside. Don't worry, we just carry on. Or that's the time that people find it most easy to communicate. Obviously, the next part, apart from the introductions, is the list as a whole. This is going to be a big list today. We've got a lot of cases on. I'm a bit worried that we won't get the last case done, or the third patient's going to be quite a challenge. I'll come to that in a minute. So we've really got to work effectively if we're going to get this to work properly. And then the individual case details, you might go through and say case by case, and it's a great opportunity for the nurses, the anaesthetist, anyone else that's part of the team to comment about the challenges that they see for that particular patient. Would you like me to do that? It's a very good form for that. And then finally, just if it hadn't been enough, just identify how the whole thing's going to work at the end of the day, and ask if anyone's got any questions or concerns. So what was the results of that within the proof of concept? This was a results of a survey, and I know survey is relatively soft data, it's qualitative data, but nonetheless, people were asked about the communication they had with surgeons. And you can see that after the end of the proof of concept, there were still, surgeons weren't particularly high. There was slightly more people felt that they could communicate adequately with their surgeon, but there's a much greater number in the very high category and relatively fewer in the low category. Some movement on surgeons. On anaesthetists, again, as a result of using these tools, the rate of good communication increased, the very high and high collaboration with anaesthetists. And the nurses was the only one that reached statistical significance, but an increase in positive communication with nurses increased 14%. So some evidence that using briefings will improve the communication within the team in our operating rooms. So what about our future plans? Well, I think there's 3 things, 2 of which I've already highlighted and a third which I'll come to in a second. The first is to improve the quality of checklist use. Not the actual use of it. We've mandated it, we've guidelined it, we've reported on it, we've done all those things. Well, I suppose we have potentially financially penalised people that don't do it right, but we've certainly encouraged its use in all the ways. But we haven't done anything to make sure it's done well. And so that's what we're going to emphasise. We're going to look at introducing briefings and hopefully debriefings as well, and we're going to do some simulation training. Now, on that picture on the right, it looks like an operating room, doesn't it? It looks pretty It looks like some nasty patient's got an amputation and there's blood all over the place, and the surgeons and the anaesthetists and the nurses look fully engaged, but it is completely simulated. So I'll come back to that because that's what I'm going to talk about for the next couple of minutes. The timeout. Talked about versions of posters that you can have on your wall to get away from the compliance-driven, tick the box and make sure 2 people have signed and then maybe somebody to sign that the first person was actually the right person to sign it, and get to something on the wall. Now this is not, I've just seen the Southern Cross one this morning, and I have to say I like that a lot better than this one. There's a couple of things about this one that always give me slight grief. One is that we put the introductions at the end, which I think is something that's counterintuitive, slightly balanced by the fact that if you do a briefing, you don't really need to fret the introduction so much in your timeout because you will have done it earlier. But the other one is a surgeon. This is the one that, so here I am, I'm doing the checklist, I'm sitting there, patient's prepped and draped, I'm about ready, and I have to ask myself a question, am I happy with the positioning? Well, if I wasn't, then why am I doing this? So I think there are some tweaks there, and I have to say the Southern Cross one that I've just seen is absolutely fantastic. So well done, and I think anyone can come up with their particular version. Again, this is something that should be right for the organisation in which you work. So, using the paperless checklist, I am confident it will increase engagement in the way that Simon's work has shown, and it will get us results from the checklist process. We will use the briefings, introduce the briefings, and I think there are challenges here. I'd love to have a little forum at some stage. I've been around the country giving talks on briefings, and I've heard almost every reason, well, I think I have, maybe there's some more, every reason why you can't do a briefing. It could be that, well, I always do my ward round before theatre, so I can't possibly do a briefing. Or, well, the nurses come at 8 o'clock and they've got a mandatory 6-minute change time and they won't be available till 6 minutes past 8. Or, no, we can't possibly start the lists 5 minutes later because then on our checklist stuff, we've got to check off late starts and it would look like every list is a late start, and et cetera, et cetera, et cetera. And I think the challenge is to find whatever the logistics are that will help you. This process will result in greater efficiencies, it will result in better teamwork, it will result in better communication, and it will result in greater patient safety. So what about this operating room simulation stuff? Well, we do a lot of stuff, if you like, on the fly as we're doing our day-to-day work. But while we simulate occasionally, we go and practice, we don't often have the whole team together that we need, that gives us the opportunity to simulate what really doing the whole operation things involved. Now, if you do it, you have to get some sort of realism, and so when we did this work in Auckland, we got Main Reactor, which is sort of the Auckland version of Weta. No, maybe it's not, but it is an Auckland company that makes props for movies. Just a mild aside, I learned a lot about making props for the movies, and what works in the movies is not actually necessarily always reality, and I think we know that, but it's also not quite reality for the people that make things in terms of the human body. For example, intestines. In horror movies, it's fantastic. You stab the person and all of their bowel falls out onto the floor, and it makes a very dramatic scene. But of course, that can never happen because bowel has got mesentery and things which hold it in, unlike a link of sausages which just sort of falls down to the floor. We had to talk to this group and explain some of the anatomy. They had no idea what a mentum was and mesentery and some of those things. I also learned a lot about blood. So we said, obviously we want these models to bleed. And they said, yeah, that's fine. What sort of blood do you want? Was it like kid going to the ice cream store? What sort of ice cream? So my next question was, well, what sort of blood have you got? And the answer was a lot of different sorts of blood. Basically, from the thin liquid stuff that is like orangeade, or the stuff that's like water, to the sort of gelled up stuff that sort of oozes and creeps and that sort of. So anyway, we got the right sort of blood. In the end, from the blood selection, we chose the right sort of blood to be part of the simulation. And the key point about this, and speaking at simulation conferences, you realise the word fidelity, we could probably have a whole seminar on fidelity. Fidelity is not that something is perfectly like what it is in real life. Fidelity means that whatever you're working with is enough to engage the individuals so they can suspend whatever disbelief they've got and completely immerse themselves in the scenario. And obviously, some of the models that are around for anaesthetists are fine to do that. For surgeons, we've got to have something that we can do, that we can believe, it's like a surgical procedure. And previously, there hadn't been models that simultaneously engaged the surgeons and anaesthetists. And there's models with IVC lacerations and various bits of bowel coming out and legs and whatever, engage surgeons enough. And I love the opportunity when people say, we call time out, say it's finished, and they say, oh, just hold on a second, I've just got to do this last couple of stitches. You just have to do the last, this model won't die, You don't have to complete that anastomosis in the IVC. It will be okay. So these sorts of models allow the entire team to be immersed in the process, each of them engaged in a process which they believe is relevant, and by doing that allows the environment in which the team dynamic works in the way that it works in the operating room. I've been engaged in events before which are focused on one aspect of the team, and that individual gets very good training out of that, but the rest of us are just props. In this entire operating room environment, we only had one person who was there to make sure things worked. Everyone else was just doing their regular job. And we measured the results of that largely using this behavioural marker risk index, which looked at briefing, information sharing, inquiry, vigilance and awareness, and inter-team information sharing. Exactly the issues of communication that we're talking about. Now, the scoring system, I just put this up because I've got a slide I just want to show you about the differences that it made. It's a rather perverse reverse scoring system as far as I can see, and I couldn't, the numbers are hard. But basically, if the score is 1, the good behaviours that I showed on the previous slide are never seen, and the odds ratio of complications or death is 6 times. If you're right down at this end, it means that the good behaviours are often or frequently or occasionally seen. So the less of those that you see, the higher number you get. Number of 1 is bad. So before and after simulation training, we had a number of 0.43 here and 0.3 something here. And although it's not dramatic, it was statistically significant. This, after the event, we had more of the good behaviours, and here are the 2 in particular, inter-sub-team information sharing and briefing, 2 things that were particularly improved by using simulation. And some of the other things were certainly not inhibited or damaged in any way by having simulation. So multidisciplinary operating room simulation is a potential tool to improve teamwork in the operating setting. We can use it in situ. I think there's some evidence that it's practical and effective, and I think we are planning to, after some discussion, hopefully, be able to introduce this into hospitals in New Zealand to augment their teamwork and communication training in the operating room. So my final slide, or penultimate slide, communicating for safe surgery, it's about teamwork. It's about effective use of the checklist, not just simply that the checklist occurs. Good communication techniques, the use of briefings and debriefings, and the regular practice of teamwork and communication in the simulation setting. Thank you very much.